Good morning, sir. Hello, good morning, sir. Hello, good morning, sir. Today my topic is anesthetic consideration, kyphoscoliosis correction. Normal spine, normal spine curves are either structural or non-structural. Uh, Structural curves lack normal flexibility and don't correct with bending towards convexity or lying supine. Non-structural curves resolve with bending towards convexity or in supine position. In thoracic region, spine curves posteriorly, known as thoracic kyphosis. In lumbar region, spine curves anteriorly, known as lumbar lordosis. Definition of kyphoscoliosis: it describes an abnormal curvature of the spine in both coronal and sagittal plane. Kyphosis is a curving of the spine that causes a bowing of the back. Scoliosis is defined as uh, lateral rotation of the spine greater than 10 degrees accompanied by verbal rotation. Sometimes scoliosis is associated with a kyphotic kyphosis, that is hunchback, and lordosis, that is swayback. Classification of scoliosis based on the etiology. Idiopathic scoliosis, in which cause is unknown. Probable contributory causes are genetic inheritance, CNS dysfunction, nutrition. It is further divided into infantile scoliosis, which occurs in 0 to 3 years of age, juvenile scoliosis, which occurs in 4 to 10 years of age, adolescent scoliosis, which occurs in 10 years or above. In congenital scoliosis, which occurs due to an insult during intrauterine period and is associated with other congenital anomalies, that is cardiac or urinary anomalies. Congenital scoliosis is classified as open and closed varieties. In open varieties, it is associated with meningomyelitis. In closed varieties, there is unilateral or bilateral failure of vertebral development, or there is unilateral or bilateral failure of vertebral segmentation. In acquired scoliosis, causes are neuromuscular causes such as muscular dystrophy, cerebral palsy, mesenchymal disorders such as rheumatoid arthritis, osteogenesis imperfecta, neurofibromatosis, trauma, and vertebral tumors. Measurement of severity of kyphoscoliosis. There are two methods: Cobb's method and Risser-Ferguson method. In Cobb's method, when muscles responsible for vertebral alignment and weight transfer downward to pelvis weaken, C-shaped scoliosis develops, that is primary curve. To prevent tipping over, the other end of spine shifted to opposite side to keep center of gravity over pelvis. The secondary compensatory curve develops. Thoracic and lumbar regions are most frequent sites of primary curves. First and last vertebrae in Lippmann and Cobb method, first and last vertebrae that are most severely tilted towards concavity are determined. Horizontal lines are drawn on the superior border of upper end vertebra and at the lower border of lower end vertebra. Perpendicular to these two lines is drawn, and the intersecting lines angles and the intersecting angle are measured. This angle is called Cobb's angle. In Risser-Ferguson method, degree of curvature is measured from angle formed by intersection of lines drawn from middle of upper and lower vertebra to the center of apical vertebra. Prevalence of kyphoscoliosis. Curves greater than 10 degrees occurs in 1.5 to 3% of population. Curves greater than 20 degrees occurs in 0.3 to 0.5% population. Curves greater than 30 degrees occurs in 0.2 to 0.3% population. Most curves are convex to the right side. Males are more likely to have infantile or juvenile scoliosis. In females, adolescent scoliosis is common. Most of the common variety is idiopathic scoliosis occurs in 70% of population. 70% of scoliosis causes. Clinical manifestations based on the Cobb's angle severity. If a Cobb's angle is less than 10%, there are no symptoms. Cobb's angle greater than 25 degrees, there is increase in pulmonary artery pressure. Cobb's angle greater than 40 degrees, there is considered surgical intervention. Greater than 70 degrees, there is significant decrease in lung volume. Greater than 100 degrees, there is dyspnea and exertion. Greater than 120 degrees, there is alveolar hypoventilation, chronic respiratory failure. Treatment of kyphoscoliosis. There are non-surgical and surgical approaches. In non-surgical, braces, traction, plaster applications are used. In surgical approaches, there are anterior and posterior approaches. Surgery is done in either single stage or combined stage. Aim of surgery is to prevent progression of the curvature of the spine, to maintain posture, to maintain progression of pulmonary dysfunction. Indication for surgical intervention is documented progression of scoliosis curves at any age. For scoliosis not due to neuromuscular disease, angle of 40 degrees may be an indicator for surgery. For scoliosis with neuromuscular problems, angle of 25 degrees is the cutoff point for surgery. Surgeries are performed in both the anterior and posterior approach. Anterior fusion involves thoracotomy or thoracoscopy, pre-anesthetic assessment. Airway assessment. Difficulties may be anticipated in cases that involves upper thoracic or cervical spine. Traction may interfere with securing the airway. In Duchenne muscular dystrophy, hypertrophy is present. Neurological assessment. A detailed neurological evaluation documentation is important because of medical legal issues. Any pre-existing neurological disease should be noted. Pre-existing neurological diseases are at an increased risk of developing spinal cord in scoliosis surgery. Respiratory system. Patients have extensive restrictive lung disease with a reduction in total lung capacity and vital capacity. Spirometry will reveal the extent of restrictive disease and presence of obstructive element, if any. Scoliosis limit the function of the respiratory muscles. The distortion of thoracic cage makes the respiratory system less compliant, thus increasing the work of breathing. In infantile and juvenile scoliosis, associated with no lung hypoplasia because the thoracic deformity is present during the period of rapid lung growth and development. In adolescent cases, decrease in total lung capacity, which is more likely to reflect the impaired chest wall mechanics that prevent normal inflation of the lungs. Surgery leads to fluid shift and third spacing, further compromising the ventilator capacity. Anesthesia and surgery further worsen the vital capacity. Patients have increased pulmonary vascular resistance and ventilation perfusion mismatch, which makes them more prone for hypoxia. All these factors carefully weighed to decide on the need for active post-operative ventilation. Vital capacity below 40% always necessitates post-operative ventilator support. Reduced vital capacity, the first manifestation. Prolonged periods of hypoxemia result in pulmonary hypertension, hypercapnia, and eventual respiratory failure. Surgery is performed to slow disease progression and prevent complications. Cardiovascular system changes are less common but more serious, primarily to the changes in the structure of the mediastinum and secondarily to the effects of chronic respiratory insufficiency on the function of the cardiac system. Displacement or compression of the heart due to thoracic deformity may not allow an increase in stroke volume necessary during exercise. Anesthesia technique. A combination of general anesthesia and epidural anesthesia is preferred. Intubation is performed with reinfused tubes. Anterior approaches to spine. In anterior approaches to spine, double lumen tubes are used for lung isolation to enable success to the anterior spine. In posterior approaches, single lumen tube can be used. A stable anesthetic depth is required to enable proper interpretation of evoked potentials. Either nitrous oxide narcotic inhalation agent technique or an intravenous technique may be used. Non-depolarizing neuromuscular blocking agents are used to maintain relaxation by continuous infusion and maintain a constant depth of block. Monitoring should include ECG, NIV, ABP, pulse oximetry, capnography, temperature probe, urine output measurement. Blood gas measurements may be done if required. IV fluid should be warmed and a warming mattress device is preferable. Positioning. Cardiovascular changes depending on the level of spine to be operated upon and nature of proposed surgery. Position changes. Peripheral nerves, eyes, genitals, and bony points should be padded and protected. Intraoperative imaging is often required. Surgical site should be placed away from the table's central support area. Prone positioning requires an uncompressed abdomen. Cardiovascular changes in prone position are raised intrathoracic pressure causes reduction in venous return. Stroke volume is reduced with minimal changes in heart rate. Cardiac output decreases by 20 to 30% of baseline value. Inferior vena cava obstruction is present when abdomen is compressed. This compression can cause engorgement of epidural spinal vessels, leading to poor surgical field and increased blood loss. Respiratory changes in prone position are significant increase in functional residual capacity and PCO2 levels in prone. Blood flow to dorsal regions is maintained in prone position. Thus, prone position is associated with a more uniform distribution of blood flow, and ventilation perfusion mismatching is improved in prone position. Spinal cord monitoring. Cervical and lumbar ganglionic areas of the spinal cord are metabolically more active, and the number and size of the cervical and lumbar feeders are greater than those in the thoracic cord, and thus the thoracic circulation is described as watershed. Distal zone is T4 to T9. Is most commonly arises at the level of lower thoracic and upper lumbar vertebrae, that is T8 to L1 in 18% of population and 90% of population arises from T7 to L2 with a left side phenomenon. It arises as a radiculomedullary artery or from the branch of dorsal branch of segmental artery, which in turn arises from the recent aorta. Its course ascends on mid-sagittal anterior surface area of spinal cord, usually less than 2.5 vertebral body length. Takes a characteristic hairpin turn at its anastomosis with anterior spinal artery. Distal anterior spinal cord vascular territory is at risk of ischemia or infarction if there is damage to the artery of Adam Smith from during surgery or during any pathology. The goal of monitoring is to identify spinal cord monitoring is to identify disruption in nerve signals quickly so that surgical adjustments can be made before the spinal column configuration is set. Wake up test is first described in 1973. It is a gross test of spinal motor function. It remains the most reliable assessment of the intact spine. A wake up test should be planned for well in advance and discussed with the patient. Because of neuromonitoring concerns, a predominantly nitrous oxide narcotic technique is typically used. 2 or 3 twitches and a train of 4 are sufficient to allow the patient to move limbs. During this test, anesthesia is lightened intraoperatively and patient is asked to perform certain commands, that is move or wriggle his toes. Once patient performs these actions, patient is put back to sleep. For avoiding frightening experience to the patient, preoperative counseling is performed to the patient. Patient needs to be assured that though patient is awake, there will be no pain or discomfort. Complete amnesia should be ensured to prevent post-operative recall. Techniques used are total intravenous anesthesia with propofol and sufentanil infusion, TIVO with remifentanil and atraquiram with reversal for wake-up test, nitrous oxide oxygen isoflurane with switch to sevoflurane. Disadvantages of wake up test are increased duration of surgery, frightening experience for the patient. It provides information on neural damage only up to the time the test is performed. Damage may occur later, which is not revealed during wake test. Evoked motor potentials. Sensor evoked potentials used to monitor. These potentials are disrupted by inhalation agents at greater than 0.5 Mach and nitrous oxide. Neuromuscular blockade disrupts motor evoked potential signals, most commonly done with these evoked potentials are used to monitor neural integrity. Appropriate peripheral nerve is evoked potentials, and the responses are recorded at the somatosensory cortex. A direct feedback is obtained testing posterior columns of the spinal cord greater than 50% in amplitude, decreasing greater than 50% increasing greater than 10% indicates an interruption of posterior column. Other features, advantages are somatosensory evoked potential continuous intraoperative monitoring. Disadvantage is it will not detect damage to motor. In motor evoked potentials, recorded after either direct stimulation or of exposed cortex or transcranial cortical stimulation of or magnetic cortical stimulation. Extremely small false positive rates are reported when combination of SSCP and transcranial motor evoked potentials monitoring were used intraoperatively. Table shows the effect of inhalation agents, more effect of inhalation agents on evoked potentials than intravenous agents. Reducing methods of reducing blood loss or blood conservation. Usually, blood loss occurs greater than in the range of 10 to 30 ml per kg. Strategies are preoperative donation. Strategies to reduce blood loss are preoperative donation, preoperative isovolumic hemodilution, induced hypertension. In preoperative donation, target hemoglobin. Preoperative donation is done if hemoglobin is greater than 11. Subcutaneous erythropoietin injection at a dose of 400 units may be used to induce erythropoiesis 4 weeks before scheduled date of surgery. and blood is collected every 4 to 7 days, starting 2 weeks before surgery. The last collection should be 3 days before surgery. Preoperative isovolumic hemodynamics is done after injection of anesthesia. If hemoglobin is greater than 10 grams and no conflict are there, then dilation can be done. Target hemodynamics is target hemoglobin is 7%. Volume may be replaced with a colloid as per existing protocol. Starches should be used with caution in view of their effects on coagulation. Induced hypotension should not be used as it makes the patient vulnerable to spinal ischemia, particularly if there are problems with positioning. In post-operative care, all patients should be in ICU. 24-hour monitoring is done. Incentives, spirometry, and aggressive pulmonary toilet are essential. Other observations to assess neurological injury, ileus, pneumothorax, dural tears, urinary complications, and SIADH retention. Post-operative anesthesia, it involves a multimodal approach, combination of primary analgesics, opiates, and regional techniques. Intravenous opiates by infusion or patient-controlled devices is the mainstay of anesthesia. Common opiates used are fentanyl, morphine, and remifentanil. Non-steroidal anti-inflammatory drugs may be used as adjuncts. Intrathecal opiates can be injected before wound closure. Epidural anesthesia makes neurological assessment difficult. Intrapleural infusions of local anesthetic or opioids can be used. Low dose intravenous ketamine is also used as anesthesia. Post-operative complications are massive blood loss, neural deficit due to prone positioning, particularly in cases when the angle defect is above 100 degrees. Higher is the chance of post-operative neurological deficit. Peripheral nerve injuries are supraorbital nerve due to direct pressure, lingual or buccal nerve due to retraction of jaw, brachial plexus axillary nerve due to excessive abduction of arms, musculocutaneous radial nerve, ulnar nerve, recurrent laryngeal nerve, phrenic nerves are injuries occur due to overextension or rotation of neck. Other nerve injuries are sciatic nerve, lateral cutaneous nerve of thigh, dorsal nerve of penis. Other post-operative complications are post-operative visual loss, pancreatitis, polylithiasis, superior mesenteric artery syndrome, chylothorax, air and fat embolism, tension pneumothorax. Post-operative visual loss. It may be due to ischemic optic neuropathy or central retinal artery occlusion. Etiology for ischemic optic neuropathy are intraoperative hypotension, prolonged surgery, excessive blood loss, large amounts of crystalloid infusion. Mechanism of etiology of central retinal occlusion is due to direct external pressure emboli. Mechanism of ischemic optic neuropathy is due to ischemia or orbital edema leading to stretching compression of optic nerve. In central retinal occlusion, there is decreased ocular perfusion pressure. Clinical features of ischemic optic neuropathy are there is painless bilateral decreased light vision and visual fields. In central retinal artery occlusion, there is painless unilateral periorbital swelling or ecchymosis. Summary. Most commonly, kyphoscoliosis is idiopathic in origin. Cardiorespiratory dysfunction may coexist with scoliosis. Therefore, careful preoperative assessment is required. Surgery aims to correct the curvature, improve posture, and reduce progression of respiratory dysfunction. Intraoperative considerations include prone position, avoiding hypothermia, fluid balance, minimizing blood loss, and monitoring spinal cord integrity. Good post-operative pain control and respiratory care is needed. Thank you. Hello, sir.
The topic is open for discussion.
Hello, sir. Hello, sir.
Hello.
Sir.
Hello, sir. Good morning, Ravi Kumar, sir. Hello. Sir, most common, what you call, nerve damage, sir, involved during positioning of the spine surgery, sir, post surgery.
Ravi, on your video and switch off any other devices you are having. Because
Ravi
based
sir,
on
మీరు
on it,
మీ
first of all,
ఫోన్ ని మ్యూట్ చేయండి సార్ రవి సార్.
and also speaker should always be visible. నువ్వు ఎవడు మాట్లాడుతున్నా మాకు ఎలా తెలుస్తుంది? Yeah, carry on. Answer the question.
Sir. Hello, sir. Omkar, sir.
సార్ చెప్పండి.
చెప్పండి రవి సార్ చెప్పండి.
Sir, most commonly brachial plexus axillary nerve injury due to excessive abduction of the arm, sir. Omkar, sir.
హలో
Hello, sir.
రవి చెప్పండి.
Sir, brachial plexus and axillary nerve అన్నా.
బ్రేకియల్ ఫ్లక్సస్ యాక్సిలరీ నర్వ్ డిపెండెన్సీ వల్ల ఎక్కడ వస్తుంది సార్? మోస్ట్ కామన్ అడిగాను, అవుతాయి అయ్యి, బట్ మోస్ట్ కామన్ అడిగాను నేను. అండ్ సెకండ్ క్వశ్చన్ సార్, టు హూమ్ డూ యూ సజెస్ట్ పల్మనరీ ఫంక్షన్ టెస్ట్? అంటే ఇప్పుడు కైఫోసిస్ స్కోలియోసిస్ ఉన్న అన్ని కేసులకి మనం పల్మనరీ ఫంక్షన్ టెస్ట్ అడుగుతామా? On what basis do we decide shall we go for pulmonary function test to this patient or not?
Sir, if there is associated neuromuscular disorder, sir, and if the kyphosis scoliosis angle is greater than 40%, we go for pulmonary function. Omkar, sir.
సార్ నేను రైల్లో ఉన్నా, నా సిగ్నల్ సరిగ్గా లేదు. శేఖర్, 2 క్వశ్చన్లు డిస్కస్ చేయవా? హలో
sir.
I am the moderator. So అందుకని చెప్పి నేనేమి క్వశ్చన్స్ అడగట్లేదు. So if you can't, I will tell you. Okay. Please, everybody ask questions so that he can understand what is what.
Sir, what is the most common nerve injured and adigaru sir, Omkar sir.
Ravi sir,
Yes.
how do we do wake up test? అది ఒకసారి చెప్పరా?
First, counseling will be given, madam, about intraoperative assessment of the somatosensory and motor component and sensory component, particular motor component. For that, the patient is advised to counseling is given. He may get awakened and ask to movement of his limbs. Then before cut off the before testing, we will taper the induction agent, the agents which are we are administering for anesthesia. It will take minimum 5 to 8 minutes to gain consciousness to perform the test. Madam. And
Sir, చెప్పండి
50% greater than 10% decrease in latency, increase in latency, and greater than 50% decrease in amplitude is considered as spinal cord anatomy ischemic changes or posterior column defect. Interruption of posterior column pathways, madam. Actual tibial nerve, the appropriate vessel nerve is stimulated and the responses are recorded at the somatosensory cortex. Madam,
Scoliosis corrective surgeries వైజాగ్ లో అవుతున్నాయా? Anyone doing?
అయ్యాయి సార్, అంటే నేను పీజీలో ఉన్నప్పుడు we had one case. శేఖర్ సార్ and me were there ఆ టైంలో. లీలా ప్రసాద్ సార్ వచ్చి చేస్తారు.
లీలా ప్రసాద్ చేస్తారు. What are the challenges did you face at the time, Chaitanya?
She was around 10 years old, 10 or 11 years old, and it was a prolonged surgery. Yeah, wake up test was definitely a challenge because she shouldn't be having pain, and at the same time she should be obeying our commands. Ante tanu cheppinappudu move cheyali, so that was the tricky part. Hemodynamic changes, not very much, but then yeah, they were there. We were ready with all blood and blood products. Yeah, these were the changes, I think.
Okay. Pain relief ఎలాగా వీళ్ళకి స్కోలియోసిస్ కరెక్ట్ సర్జరీస్ లో ఐడియల్ గా హౌ డు వి మేనేజ్?
Infusion, sir. Patient controlled analgesia, sir. 1 to 2 micrograms fentanyl infusion, sir.
1 to 2 microgram per hour per kg ఏంటది?
Morphine also is also another option, sir.
How you give intravenous?
Sir,
Intravenous epidural
epidural, sir.
huh?
Sorry, sir, intravenous, sir. Intravenous. మామూలుగా ఆపరేషన్ క్లోజ్ చేసే టైంలో ఎపిడ్యూరల్ గా లోడింగ్ డోస్ ఇచ్చి క్లోజ్ చేస్తారు, సార్. దాంతోపాటు అడ్జంక్ట్స్ కూడా వాడతారు సార్, నాన్ స్టెరాయిడల్ ఏజెంట్స్ కూడా.
Intravenous 1 to 2 mics post-op anesthesia. Patient other opioid related complications ఏమన్నా ఉంటా ఆ డోస్ తోనే?
అంటే పేషెంట్ కంట్రోల్ అనాలిసిస్ కూడా ఉంది సార్ కాన్సెప్ట్. ఒకవేళ తగ్గకుంటే గిన టాప్ అప్ లాగా.
The patient doesn't know that side effects will come now. Chaitanya, how did you manage at that time for the 10-year-old? Because generally we see even with 50 mics per hour infusion also opioid related side effects are high. The post-op intravenous opioid analgesia for an awake patient, I'm not sure how it's going to work. Pain will come down, but we have to tackle with other problems, I think. Morphine also at that age group we can give maybe safely.
రెమిపెంటిన్ అని కూడా ఉంది సార్.
Epidural?
ఎపిడ్యూరల్ సర్జరీ క్లోజ్ అప్పుడే ఇస్తారు.
Your voice is very low, Ravi.
ఎపిడ్యూరల్ సర్జరీ క్లోజ్ అప్పుడే ఒక బోలస్ డోస్ ఇస్తారని ఉంది సార్.
No, how? You will pass a catheter or
డైరెక్ట్ ఇన్స్టిలేషన్ సార్.
direct installation into epidural space.
క్లోజ్ చేసే ముందు ఇచ్చేసి క్లోజ్ చేస్తాను.
Bolus dose epidural ఎన్ని అవర్స్ వర్క్ అవుతుంది? ఐడియల్లీ లాబ్రనాలజీ షాట్లో అన్నిట్లో ఇస్తాం కదా. So do you think that 2 hours or 3 hours window will be sufficient for a scoliosis corrective surgery pain relief?
సార్ ఎపిడ్యూరల్ ఇచ్చి తర్వాత మళ్ళీ ఐవి పెట్టేసుకుంటాం సార్.
సరిపోతుందా?
అంటే డెక్స్మెటోమిన్ గురించి ఇవ్వలేదు సార్. మెయిన్ ఓపియాడ్ అనే కాన్సన్ట్రేషన్ దాంట్లో ఉంది సార్.
What about facial plane blocks?
ఐడియా లేదు సార్.
ఎరెక్టర్స్ పైన కానీ పారావర్టిబ్రల్ కానీ
పారావర్టిబ్రల్ అంటే
శేఖర్ ఇచ్చారా? అంటే ఐ డోంట్ హ్యావ్ ఎనీ ఎక్స్పీరియన్స్ ఫర్ స్కోలియోసిస్ కరెక్టివ్ సర్జరీ, జస్ట్ థింకింగ్ ఆఫ్ స్పైన్ సర్జరీ అండ్ స్పీకింగ్.
At the time, we didn't give anything actually.
Okay.
We just managed with intravenous opioids and non-steroidal anti-inflammatory drugs అంతే, అంతకంటే మించి ఏమి ఇవ్వలేదు.
Now with all this facial plane, ఇవి ఎఫెక్టివ్ గా వర్క్ అవుతాయేమో కదా మోస్ట్ ప్రాబబ్లీ.
Yeah.
ఎరెక్టర్స్ పైన కానీ పారావర్టిబ్రల్ కానీ ఐ థింక్.
Yeah. Now we have some expertise in doing erector spine and everything. At the time, I was just out of my PG, so we didn't have that much experience with that. So ఇవ్వలేదు అప్పుడు ఏమైంది.
Hello.
హలో సార్.
Ravi, listen one thing. For any presentation, you need to have either of the two. You should have a very sound theoretical knowledge about the topic if you are not experienced in doing the case, or you should have a good experience of doing that case.
Okay.
At least 2 or 3. ఈ రెండు గుర్తుపెట్టుకో. అంటే now that again you have entered student life and doing DNB కాబట్టి. సో లేదంటే ఎగ్జామినర్స్ ఆడేసుకుంటారు నిన్ను, డౌట్ లేదు నేను స్లోగా ఉన్నావు అంటే. Yeah, Arvind, carry on.
Yeah, sir. Generally, I mean, for these types of cases, epidural anesthesia, as far as I know, it is not contraindicated, but not given because the neurological assessment will be difficult, sir, post-operatively. And main post-operative analgesia will be a multimodal approach only, like primary analgesics and opioids and a combination of few regional techniques. But main will be like he said, IV fentanyl or with a continuous infusion, or we'll have to titrate the doses or intermittent bolus doses only.
Moving towards opioid-free anesthesia kada 10 years back.
Yeah, but this is extremely painful procedure, sir. So I don't know, people generally use more opioids in these surgeries, sir, especially.
Okay, అందుకే actually I don't have experience in scoliosis అంతా అడుగుతున్నాను. So what did they follow on case చేసినప్పుడు?
And in Omkar sir ఉన్నారా సార్?
సార్ ఏబిసిగా వస్తున్నారు, లిస్ట్ గట్టిగా ఉంది.
ఓకే, అదే మోస్ట్ కామన్ నర్వ్ ఇంజరీస్ అని ఇందాక అడిగారు కదా, ప్రోన్ ప్రొసీజర్. దీంట్లో జనరల్లీ అంటే మోస్ట్ కామన్ తెలియదు కానీ ఆప్టిక్ నర్వ్ ఆర్ ఇదే lateral femoral cutaneous nerve of thigh, ఆ 2 సార్.
ఓకే సార్.
2 and 3
ఓకే.
2 and 3 సార్. 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 యాక్చువల్లీ ఇంకోటి ఏదో కూడా క్వశ్చన్ అడిగారు, అదేంటో తెలియదు.
Okay. Okay. Anything more to add, Chaitanya, Omkar, Shekhar, Manshula madam కూడా or Ravi is waiting to wind up the session.
Sir, most common cause, why should there be post-op vision loss, that complication? Enduku? What is the main reason?
ఇస్కెమిక్ న్యూరోపతి, ఇస్కెమిక్ ఆప్టిక్ న్యూరోపతి.
Sir, Ravi sir చెప్తారు.
ఓకే, సారీ.
యాంటీ ఇస్కెమిక్ ఆప్టిక్ న్యూరోపతి మేడం. ఇస్కెమిక్ డిక్రీజ్ ఇన్ పర్ఫ్యూజన్ ప్రెజర్, ఆప్టిక్ నర్వ్ పర్ఫ్యూజన్ ప్రెజర్ వల్ల మోస్ట్ కామన్ కాదా మేడం అడిగింది మీరు?
Yeah, ischemic optic neuropathy is the most common cause అనుకుంటా.
అదే మేడం.
Yeah, ischemic optic neuropathy is the most common cause because these are prolonged surgeries, kada. That's why there is a chance of. That's why it's also important to give adequate fluid management. Unless there will be fluid deficits, and if there is any fluid deficit, and because of the surgical stimulus and everything, the coagulation cascade will be activated, and there will be central venous thrombosis and CRVO, and it can also lead to arterial thrombosis also sometimes. But the most common cause is because of the dependent position and everything, the optic neuropathy is commonly seen. That's why postoperative visual testing should be done in these patients.
The correction involving more than 4 vertebra, higher chances of injury అని ఉంది సార్.
That's obvious, no, Ravi?
Sir.
So if the
That will
patient
take
is
more
having
time.
that will take more time, that will take more dependence of the eyeball and everything.
Sir.
The gravity time will be more, and the surgery time will be more, and we need to maintain the patient adequate hemodynamics, and the chance of hemodynamic disturbance will also be more. Everything compounds, no? That's why. If the patient is having only 1 or 2 levels of scoliosis or kyphosis, so then it's not a major issue. If it is more than 4 or 5 of the whole spine, what we did was a whole spine hyposcoliosis correction for the 10-year-old or 11-year-old, I think. That took almost 12 hours for surgery only. In those cases, there is a high risk of having postoperative visual loss and everything, compared to only only lumbar or thoracic scoliosis or kyphosis.
Sir, and also this compression of the abdomen also, sir, during placement of and positioning. When we put the head below the level of the heart, also it can also raise this orbital pressure, and along with that, like you mentioned, volume deficit and hypotension, sir. These are all of these combined to they result in ischemic neuropathy, sir.
Yes, sir, that's right. Any more questions?
Srikanth sir?
Okay, we will stop here, Ravi.
Sir.
Okay.
Thank you.
Okay. Right. Thank you.